we are going to be ready to go. So hello everyone, this is Kathy Bush and welcome to the DandleLION medical webinar titled Using Quality Improvement as a Change Mechanism for Improving Developmental Positioning in the NICU. Our faculty presenter this morning is Dr. Elizabeth Jeanson, and we also have with us this morning Alex Luton, our DandleLION Director of Education, and Kathy Randall, who is our tech guru and expert question answerer. So I'd like to introduce you to Dr. Elizabeth Jeanson. She currently serves as the developmental specialist in the NICU at Sanford University of South Dakota Medical Center. As the developmental specialist in PT, her responsibilities include direct patient care, developmental care programming and policy, family and community education, quality improvement, and she's also the administrator of the neonatal therapy team. Elizabeth completed NICAP training and holds the Infant Behavioral Assessment Certification. She is also NNNS and Neonatal Touch and Massage Therapy certified, and she's presented nationally on many topics, including sensory development of preterm infants, positioning of infants in the NICU, non-pharmacologic pain management for preterm infants, change process and quality improvement, infant-driven feeding implementation, as well as team building and strategic planning for multidisciplinary teams. And in 2013, Elizabeth did publish an article in Newborn and Infant Nursing Reviews entitled One-to-One Bedside Nurse Education as a Means to Improve Positioning Consistency. Elizabeth's passion is improving the outcomes of premature infants through evidence-based practice, family support, and staff education. So that's a great intro, great bio. We are so excited. Welcome, Elizabeth.
Hi, everyone. I'm so excited to be here today. I'm thankful to Kathy for asking me to present this topic. We met at a conference and I couldn't wait to tell her all about it because it was so exciting to me. And I was fortunate that she asked me to share it with all of you. Today, we're going to be talking about exactly that, quality improvement. I hope that's not something that you dread. And I hope today that I can make that something that you're really going to like and see as a valuable tool for imparting change in your unit. Let's get started with just the necessities. I have nothing to disclose. Today, I'm hoping that you will be able to come away with at least 2 helpful quality improvement tools that you can use to implement a project in your unit, as well as what would be appropriate variables to pick when you're looking at positioning, and then also some ways to get that staff involved in the process. Throughout this presentation, you're going to be seeing a lot of pictures of babies in positioning equipment. These are all pictures from my unit. Parents have graciously allowed me to use these pictures, and I'm thankful to them because they really demonstrate the different pieces of equipment and how they can support good developmental care. I do indeed work at a castle. As Kathy mentioned, I'm a developmental specialist and also a neonatal physical therapist. I work at a level 4 upper Midwest, fairly large NICU. And I work in this castle. It's pretty cool. My career is enchanted. I have my dream job, actually. As a developmental specialist, my responsibilities include overseeing all of the developmental care policies and procedures for our unit, overseeing the education dealing with developmental care for our staff, families, and our community, as well as doing the quality improvement work related to developmental care in the unit. To pay for all of that time, I also provide direct patient care as a physical therapist in the unit. I work with our smallest babies. A minimum of half of my time on a daily basis needs to be spent in direct patient care. Now that's great because that affords me connection to all the nurses, the physicians, the families, and the babies. So while I'm doing that patient care, I can also work in the background to make sure that the care everyone is providing is developmentally appropriate. Our NICU is actually across the little sky bridge in the building next door in the what's called the surgical tower. And that surgical tower is sandwiched between labor, delivery, and postpartum and the pediatric hospital in the castle. Now, I do work in the castle in that this top floor of the castle is our NICU overflow. So when we get too many babies in our unit, which is over 50, 55, we have 12 rooms in the castle. So we go back and forth between the castle. Also, our ECMO suite is in the castle. When we first built our NICU in 2005, we didn't build it planning to do ECMO, but of course now we're level 4 NICU, so we do ECMO, but we didn't have enough space to put the suite. So when our babies require ECMO, they are over in the castle. So I do get to go to that castle pretty often, and it's as sweet of motif inside as it is outside. Before we start talking about quality improvement, I wanted to share with you why a physical therapist, particularly me, is so enthusiastic about quality improvement. Most people don't think of physical therapists when they think of quality improvement. You think of nurses. That's who I always thought of. But after getting into some quality improvement education, I realized that a physical therapist, occupational therapist, any staff member can really use quality improvement to make change happen. About 2 years ago, I attended a course on entrepreneurship, and it was a great course, well worth the money. I'm still not sure I want to be an entrepreneur, but I did learn about something in the course called the Enneagram. Now, the Enneagram is a personality theory, and that's kind of like one of my special interests is personality. Anyway, as I researched the Enneagram and got more and more information about it, I found out that I am a Enneagram type 1. Now, being a type 1 has nothing to do with being number 1. It's just the type number. Anyway, a type 1 is called the reformer or the perfectionist. And anyone who works with me closely will know that perfectionism can be my downfall. However, this personality type loves order and rules and processes. They love to use that to figure out new knowledge and how that new knowledge is going to fit into situations so that you can determine what is the right thing to do. Perfectionists love to do what's the right thing to do. Well, quality improvement is exactly that. You use a process to determine what's the best protocol, best piece of equipment, least expensive, most efficacious, and then you put that protocol into place and you monitor it. So you know you're doing the right thing in the right place at the right time. Quality improvement lets you find out what is right, and it's a real truth teller. Let's take a moment to be clear. Research is taking what is unknown and converting it into what is known. Okay, evidence-based practice is applying that new known into specific populations, situations, and environments to find out what's going to happen when the new known is put into those situations. Quality improvement is assessing of that is known, what's best for my environment, what's best for my patients, what's best in my situation. And then performance improvement is making sure that what is best is continued over time in the same way. When some people think of quality improvement, they just think, yuck, I don't ever want to do that. Don't those people just track Joint Commission required variables like CLABSI and falls and HAPPIs? It's more like quality monitoring than improvement. And I felt that same way when I started this work. I'm like, what's a PT going to monitor? We don't have those things that affect those Joint Commission variables. However, some people also think that quality improvement has to last forever. It's got to take years and years to prove that this is effective. That might be true for research, but it's not true for quality improvement. Actually, shorter quality improvement might even be more effective. The tracking that we're talking about of those JCO requirements, or maybe they're hospital requirements or OSHA requirements, that is performance improvement. I'm here to tell you that tracking Joint Commission variables is not what this talk is about. We're here to talk about quality improvement, a way to produce new outcomes using new equipment or new protocols or new environments, to really use quality improvement to prove that something is better And when you know something is better, everyone does want to do it. To begin our journey, let's get into a quality improvement mindset. It really is a way of thinking. And since I've been doing this work, I can't even get away from it. It's the way I think about everything when someone comes to me with a complaint or a recommendation or something they saw at a conference or something they saw online. I automatically go into my quality improvement mindset. So let's talk about that a little bit. That's just where you overhear a conversation or you participate in a conversation. Maybe you're in the lounge, maybe you're at the bedside, maybe you're in the cafeteria, maybe you're just walking down the hallway and you overhear people, or people come directly to you and they say, hey, I saw this, I heard this, I read this, I hate this, I like this, this doesn't work for me. This never works, I'm so frustrated. So you take that information that you get in just a casual conversation and you start to think of an idea. How can I make this better for you? How could this be better or more effective? Okay. Then you want to gather evidence. What evidence is there about this specific subject? Are other people doing it? Are there white papers? Is there research to support it? Do I do something similar? And this is just a little different. Start to gather that evidence that's going to support your new protocol. Okay. Then you want to seek perspective. You want to ask all your stakeholders, what are their thoughts about that new idea? Everyone's going to come at it from a different perspective, which in this positioning protocol, that was so evident that every stakeholder had a different goal in mind. Okay. After you gather perspective, then you want to check that against what are your hospital goals and what are your overall system goals. Every hospital, whether you know it or not, I'm sure you do, has overarching goals, national patient safety goals, JCO goals, best hospital in the upper Midwest goals, and each department has its own goals. Our department has NRP goals. Our department has staffing goals. Our department has new protocol for hospital documentation goals. So you want to check your idea against what are those goals. Okay. Then you want to create your intervention process, and really important is figure out how you're going to pay for this. Is it a staff cost? Is it an equipment cost? What's the cost and how are you going to pay for it? Okay. You determine your protocol. Then you need to educate your staff about what that new protocol is. The more education, the better. You want to collect data. Then you got to analyze that data and draw your conclusions. Is this actually better? Does it save time? Does it save money? Is it better? Are babies more comfortable? And then you need to present that new information. I can't tell you how many times I've been at a conference and I've been talking to somebody about a specific problem that I'm encountering, and they say, oh, we did a project on that 2 years ago and we found this to be true. Like, how come you haven't shared that with anyone? So when you do quality improvement, you really do need to share it with someone other than just your department. Here at Sanford, we have an annual quality fair where every department across the system has to produce a poster, a quality improvement poster or project, so that at least everyone in our system is aware of the work that's being done at every level. Examples of a QI mindset on our unit right now, right today, are we're really unhappy with our BPD rates, which I'm sure everybody is. And that led to the idea of, could we create a super management of non-invasive respiratory support? Is there a way that we could super manage CPAP and NIPPV? And they created a protocol, which we call Keep the PEEP. Now, Keep the PEEP means that for 72 hours, we do not remove the interface unless you absolutely have to, for skin checks and for suctioning. Like, otherwise you don't remove it. Anyway, we do that for 72 hours. And what we've done is we've collected data on that about how many times the interface is interrupted and the PEEP is lost. We collected it before we implemented. We collected it after we implemented. And what we found is that with Keep the PEEP, we do not interrupt the interface nearly as often. And those babies have been able to wean their CPAP NIPPV support faster. A second example would be our OT. Our OT was noticing that babies never got a tub bath in our unit until they were 42 to 44 weeks. Now, that's not many babies in our unit because our units, we're pretty good at getting babies out before term. So those few babies that reached term or post-term, that's when they started to get a tub bath. So we had parents who went home from the NICU who never learned how to give a tub bath to their babies. We even had some parents at NICU follow-up clinic who stated that they didn't bathe their baby in a tub for 2 or 3 months after they went home because they were so afraid of what to do. They were so afraid their baby was going to get cold. Anyway, so our OT got an idea, like, is there something we can do? Can we create a new protocol for swaddle bathing that we can do with younger babies? Anyway, she went to our director, the NICU director, and she brought up that idea. And the NICU director was all on board, like, yep, let's do that. We have these ridiculous, gigantic tubs that nobody can fit in. They're super cute, but nobody can fit in them. Is there a better tub? Is there something else we should be doing? So our OT set out, she looked at all the tubs, she created a protocol, and we're now in the process of doing the staff education for that protocol. So we can do swaddled bathing with a little bit younger baby. It's a perfect example of quality improvement mindset. Finally, I just wanted to tell you one more. Just the other day, I got a message from an OT that works in our sister unit in Bemidji, Minnesota. So that's pretty far north in Minnesota, and it's a small unit, but she was concerned about the parent education and interaction at the bedside. And she wanted to know, was there anything that anyone else was using? So what's the current state, gathering her evidence, what anybody else was using to address the needs, educational needs of parents while they're in the unit. Anyway, so she sent this out. She's gathering her evidence of what's happening. And she had heard about a commercially available parent education package. And she wanted to know, was anyone else using it? Had anyone heard of it? She was going to find out what the cost of that was. In our unit, we use an in-house parent education packet, which we like because it's catered specifically to the babies that we care for. But we're going to compare that as a system to the commercially available package. And then we're going to compare the two and see which one really is better. And then it's specific to our environment of our system. Just another great example of how that quality improvement mindset works to find out what really is better for our patients and our staff members. Okay. These are just some examples of the quality improvement projects related to developmental care that we've been doing the last few years at our hospital. Actually that's wrong, it was 2013. Sorry about that little mistake. In 2013, we did one-on-one bedside education to improve positioning consistency in the NICU, where we looked at, is it better to do group education or one-on-one education? Then in 2017, another project we did was shaping babies' futures one head at a time, where we looked at reducing positional plagiocephaly. We did using the 4 disciplines of execution to implement infant-driven cue-based feeding in 2018. And in 2019, we looked at what was the reduction of cost in our unit using that same infant-driven cue-based feeding program. In 2018, we began looking at positional stability of infants in the NICU, and that's where we did our quality improvement project comparing different positioning devices. In 2019, we did a holding wrap to increase parental confidence, duration and frequency of skin-to-skin holding. In 2020, just last year, we did use of a positioner to reduce occipital happies. And then we did, and last year we also did improving positional stability in the NICU 1-year follow-up. So if you've been paying attention, you will realize that that 2020 project on 1-year follow-up was actually a PI project, performance improvement, versus quality improvement. One thing you have to follow quality improvement with when you introduce a new protocol and you show that it's better, you have to make sure you're still doing it. So this was the follow-up a year later to make sure that our staff were still doing what they were supposed to be doing. So it's a PI project. So if you've been paying attention, you get a gold star for noticing that that's a PI project. Most people are familiar with this quality improvement model, Plan, Do, Study, Act. We use this model in our hospital use. We also use the Iowa model for quality improvement, but Plan, Do, Study, Act is the most popular, and it's probably the quickest and easiest model you can use. You simply plan what you're going to do, you do it, you implement it, then you study, gather that information, what happened, what are the parameters, what happened to the variables, and then you act. You either refine that protocol, you adapt the protocol, or you extinguish the protocol. What quality improvement isn't? Quality improvement is not taking your own personal idea to change about something that no one else thinks needs to change. I had this when I first came to Sanford. We were using blanket rolls to position babies, and everyone thought that was fabulous. So when I came in and said, wait, this is not fabulous, babies are out of alignment and they're not in midline, and we should do something different. It took a couple years to convince people that what they were doing wasn't good enough and they needed to change. So I couldn't have just walked in the door with my new positioning products and said, do this, because they didn't recognize a need to change. So it can't be your own personal idea. That goes back to that conversation and gathering people's concerns. Secondly, you can't bring new equipment into your unit if you work for that company, if you have a stake in that company's shares, or if you'll somehow get some kind of recognition, honor by bringing that in, and the company now recognizes you as their super user expert for only that purpose. Quality improvement is not unspecific. You have to have details, and those details matter. Your variables have to be the same pre and post. Your variables have to be measurable. You can't have esoteric variables that aren't truly measurable or objective over time. That's really important. And your protocol consistency matters. You got to do the same thing every time you do that protocol to see if it really makes a difference. Quality improvement is not interruptible, meaning you can't begin it and then take a break because the staff didn't like it and then restart later, because when you restart later, the culture is different. It's not the same. So you really need to begin it, do it, and finish it to gather your information. And finally, quality improvement is not unreportable. Like I said before, you really need to share this information, whether it's some protocol you implemented and things got better, yay, share that information, or a protocol you implemented and things got worse, you still want to share that information. Everyone in healthcare needs to know what doesn't work as well as what does. Basics of quality improvement. Oh, I think I've got one slide out of place. Okay. So one of the things we've already kind of talked about is variable selection. It is really important that your variables reflect the change you're asking for. And the variables have to be the same pre and post. So you can't pick something pre that you don't like and then have an implementation and measure something different post and compare those two. Apples and oranges can't be compared. So you got to do the same thing before and the same thing after, and it has to be measurable. Now there's lots of ways to measure things. You can measure patient satisfaction with a Likert scale. You can measure time, you can measure frequency, you can measure staff opinion or staff's perception with a lot of different tools. But you do have to use a tool and you have to measure it. You want to do an abbreviated duration of your trial, the shortest trial possible to get the information you want. You don't have to do something for 2 years to demonstrate that it's effective. You want to have a predetermined sample size. In our project, our SVAT committee, which is Systems Value Added Task Force, determined how many products they were going to purchase. And they told me that I had to use every one of those products to determine if they were truly better. So they determined my sample size for me, but you'll want to determine what sample size you want for your project before you start. You want to figure out a protocol that's going to demonstrate something is better than what you had before. So you have to compare the two, before and after, pre and post. And then you want to make sure that it's aligned to one of your hospital or your department goals. I can't tell you how important that is and how much cred your project will get if it's aligned. Let's talk about that positioning project that we did. Now we're ready to talk about it. What did we do? Well, from 2004 until 2018, our NICU used a soft hip and leg pocket positioning device that we paired with a keyhole-shaped tummy line device, which we also compared with a short-legged beanbag boundary and a flexible bendable boundary, as you can see here in this picture. We used a tool to assess how well our staff was using these positioners and how well the positioners supported midline flexion, the gold standard of positioning, to promote good sensory motor development. The tool we used was called the iPad. The iPad is the Infant Positioning Assessment Tool, and it's available from Philips. And it allows you to compare real-time positioning with a gold standard. The iPad was published in 2018, and it's a pictorial representation of that optimal posture, and you can compare your live baby to the standard. In 2018, we initiated a quality improvement project comparing our familiar devices that we've been using since 2004 with a new product line that we had never used in the unit before. Because of that long-standing use of those products, our staff was very comfortable with them, and it was very much part of our culture that this is how babies should look and be supported. Staff, because of that familiarity, changing their minds and their habit was a challenge that my opinion alone was not going to work to get them to change to this new product. And furthermore, my opinion wasn't necessarily true. It was just an opinion. I had to demonstrate that the new products were better, and what better way to demonstrate something is better than a quality improvement project. So I surveyed our stakeholders about what they wanted. If we were going to change positioners, what did they want to have happen? Well, our administration wanted it to cost less, and they wanted to improve the patient experience. They wanted parents to say, "This is great. I recommend this hospital." They didn't really care for midline flexion or how often we changed the position or how much pain the babies were in. They just wanted it to cost less and to improve patient experience. Our physicians, they wanted it to reduce the number of sedation and pain medications babies were receiving. That was really important to them. They also wanted to see improved weight gain, and they wanted to see improved autonomic stability, less spells. Don't put them in something that's going to make them have a spell. Our nurses, they wanted ease of care. They wanted something that was going to ease the cares that they had to provide. They wanted something that was easy to use. That was really important to them. They wanted something that provided comfort, improved sleep, reduced pain, and again, reduced spells. Our therapists, they wanted infant comfort for sure, but they also wanted proper posture. That was super important to our therapy team, and sensory feedback, that the babies were going to get some kind of feedback to their body to help reinforce that proper posture. Our parents, most interesting, they wanted comfort, they wanted pain relief, but they wanted normalcy. They wanted their baby to look as normal as possible from the earliest days on. An interesting thing I heard on the radio just the other day, literally 2 days ago, driving to work, there was a commentator on, and I can't remember what they were talking about, families, family life, and he was saying about how he had these triplets at 26 weeks, and I thought, oh my gosh, this is perfect for my presentation. How is this happening? Anyway, he was talking to his guests about the first few times he saw those triplets, and he was remarking about how alien they looked, that they didn't look like babies. In fact, to him, they looked like eels. I'm like, ugh, eels? But parents really want their babies to look like babies as soon as they can. So you might be unfamiliar with the different positioning products that are available. So we're going to review those really quickly. There's only 4 companies that are making positioning products for premature babies in the NICU: Philips, ShapeRite, the Fluidized Positioner, and DandleLION. Philips provides these products. They have the hip and leg pocket, soft pocket positioner. They use a short leg bean bag. They have the keyhole shaped tummy line device and a bendable, flexible outer boundary. And when you put them all together, you get a baby who's positioned as above. Now, Philips has recently announced that they're no longer going to be manufacturing these products, so they're not going to be available for us to use. So we really can't keep them in our line of positioning equipment that's going to be available. Secondly, there's the ShapeRite system. And the ShapeRite system is a soft, flexible boundary that just molds around the baby. It's all fabric and foam. It's washable, it's easy care. And you can use it to provide this kind of 360-degree boundary for babies. Then there's the Molinicki or Molinike, I never say it right, Fluidized Positioner. And these Fluidized Positioners start out like flat rectangles, and they're made of a material that you can smush around the baby and hold the baby in exactly what position you want them to be in until you unsmush them. They come in different sizes. We did use this smaller positioner when we did our quality improvement project about reducing occipital happies for our sickest babies. Then there's the DandleLION line. The DandleLION line, they make these positioners. They make this 360-degree soft, flexible boundary called the DandleRoo. They also make the little wrap where the head is not contained in the little hood. They make a cranial molding mattress to help maintain proper head shape. They have a product similar to the DandleRoo, but it allows Billy Light penetration. Just a little caveat about that. Our unit was very hesitant about anything that was going to interfere with Billy Lights. So our residents were assigned to do a quality improvement project where they looked at how much light is penetrating through this DandleLION product and how long were babies on Billy Lights if we use that product. And I'm happy to say that they determined that 72% of the light did penetrate through the product, a single layer cover of the product, and that it did not extend the length of Billy Light use over time. And finally, when you put it all together, your baby might look like that bottom picture. What you can't see, or maybe you can't see it very clearly in the bottom picture, is they make a similar long beanbag product for positioning, but it has long legs and a special addition that you can wrap over it to increase the height. So what makes a positioner a good developmental care positioner? Got to keep that in mind when you're looking at what we're providing for babies. It needs to support normal body curves. It needs to support that fetal position. It needs to prolong sleep. It needs to provide comfort. It needs to have proprioceptive feedback, as well as be warm and soft. It's really important for our hospital that it be reusable. It has to be washable and sturdy. It has to accommodate head of the bed elevation. It has to stay put. It has to accommodate tummy lying, back lying, and side lying. It has to be temperature neutral or regulating. It has to be easy to use and inexpensive. We ask a lot of our positioners in the NICU. Let's talk about some of those quality improvement tools that I use during this project and all projects that will be helpful for you as well. They're the project charter, the 100-day plan, and the report out. Our quality improvement projects are always limited to 100 days. So about 3 months time to get your project from idea to presentation. At Stanford, quality improvement is very important, and I can't imagine that it's not super important at every hospital all across the country. We have a quality improvement, we have a quality department, and they put together a toolkit that has probably 50 different tools that you can use when you're doing quality improvement projects, both for the novice as well as the experienced quality improvement worker. These are my 3 favorites and very, very effective. We also have a tool that I'm not presenting today, but you plug your data into it and it creates a magnet graph of pre-intervention, intervention, and post-intervention. Very wonderful, easy tool to use. But unfortunately, I can't show you that today, but you'll see the effect of that when you look at our graphs from our project. Anyways, today we're going to talk about these 3. And if you use these 3, these will basically write your quality improvement poster for you. So let's start with the project charter. The project charter outlines and defines your idea. It's an excellent source for creating that poster presentation. You begin with what's known about your subject. That's that background and description. What's known, why is it important, what are you planning to achieve? Then your objective, what exactly is the goal of this project? You could give it a title, but I always wait kind of till later to give it a definitive title so I can kind of see how that quality improvement project is going to go in real time. You might change your subject from improving positioning to avoiding positional mistakes. Anyway, your metrics are your variables. So your outcome metrics are what variables you're going to measure, and your process metrics are what variables, what things affect your variables, but you're not measuring them. For example, maybe I think that red cars are faster than blue cars. So I'm going to do a project where I'm going to measure miles per hour, and I'm going to measure acceleration. So that will be my outcome measures. Now, my process metrics would be how many red cars are available, and is there a test track on which I can do this actual test? Okay, you want to define the impact on your patient. Exactly what do you hope will happen for the patient? What strategic objective? What's the hospital goal that you're addressing with this project? You want to make sure that those hospital goals might be patient satisfaction. They might be financial goals. They might be joint commission goals. They might be safety goals. There's a lot of different overarching goals you can attach to, but you want to be attached to one of them. You want to have the scope of who is in your project and who isn't. For our project, we included all the babies that were preterm babies less than 34 weeks in isolates. We did not include any 35 or 36 weekers who might be in the PICU, or anybody over 34 weeks who is in a crib. Okay? You got to define that who is in your study group. Okay, you have to define what might stop or slow down. Those are the constraints, like what might get in the way of your project, like getting the equipment, or high staff turnover, or when you watched them the first time, they all fell apart. Like those things would be those roadblocks. And then you want to identify who's on your team. Some people really like to see their name in print. So they want their name on your poster, and you'll have it right here. And then other people will judge the quality of your poster based on which administration person was supporting it. So you want to have their name on there too, your executive sponsor. Okay. Finally, you just define your team of who's going to be there to help you out. All of this information can get imported right into your poster. Here you can see our project charter for our project. So our title was Improving Positioning Consistency Using a Novel Positioning Equipment. Our background talks about the importance of sleep, reduction of pain, that perception that parents have that their babies are normal infants and that they're getting just the best care and comfort and management. Our objective was to determine, is this positioning device system better than what we are currently using? The outcome variables that we measured were sleep, IPAT score or proper posture, and parent perception of comfort. Things that affected those were how do we get the staff educated? Were the positioners available, and how did we launder them and get them back into the unit in a timely fashion? The impact on the patient was improved comfort, sleep duration, weight gain velocity, postural alignment for motor development. Our strategic objective was patient experience, and then a cost objective of reducing the need for analgesia or pain medication sedation. Who was in it? As I said before, everybody less than 34 weeks who was in an isolate. Who wasn't in it is anybody who was in a crib or anybody over in the PICU. Our constraints were budgetary. How are we going to pay for this? And then staff engagement. Was the staff actually going to try these products? My executive sponsor was our VP of Women's and Children's, and that was very helpful for me. She was so helpful for me in expediting getting the equipment. Let's look at that 100-day plan. This is what the 100-day plan looks at. It literally is 100 days, and it goes through each phase of your project, from defining your project, which is what are my goals, what are my variables, what are the parameters, What's the next thing I need to do to get this project off the ground, like administrative approval, supplies, educational materials. Then the current state of analysis. What's your pre-implementation data? Got to collect that so you can compare it. So what time frame are you going to collect that data in? How long are you going to collect it, and specifically what you're going to collect it. Then design and development is, I proved I had a problem. Here's my solution. So that's design and development. Then you do your implementation, which is a specific period of time from start to finish where you're implementing and gathering your data. And then you're going to analyze, part of implementation is analyzing that data and figuring out the answer. And then you got to show how you're going to monitor and sustain that at the end of your project. So I've determined that this is better. I showed that it was better. I presented that information to other people. Now, how am I going to make sure that that continues to happen over time? So the best quality improvement projects turn into performance improvement projects. A third tool for quality improvement is called the report out. And it's simply a way of giving feedback back to your executive sponsor about how your study is coming along. And the reason for this is because your executive sponsor or your NICU director can help overcome any roadblocks that you're experiencing. So we do this at least one time in the course of every quality improvement project. And it's an easy form to fill out, and it just looks at what's the progress and what are your challenges. It can be very helpful for gaining support and momentum. So it's simply you put the objective of your project, which you take right from your charter. You put your metrics, which you take right from your charter. You assess if it's green, yellow, or red. Green meaning everything's working well and we should meet the time assigned on our 100-day plan without a problem. Yellow means that there's some challenges that have slowed our progress, but we're able to meet those challenges and overcome those roadblocks. And red means that there's a roadblock that we cannot overcome and we need help to overcome that. A roadblock might have been that you couldn't get your positioners. That would be a roadblock. Or you had specific staff that were sabotaging the process. That would be a roadblock. You're going to put on what's your action? What are you going to do next to help overcome those roadblocks? What might be future barriers? And then what is your next step? So here's an example of our completed report out. Talks about, again, I took the objective right from my charter. I took the metrics right from our charter. We were green because our positioning devices had arrived, but that was actually, we were actually red because we couldn't get those positioners, not because of any problem with the company, but with a problem with how things are ordered from our on our hospital side. So that really delayed the implementation of our project. But once we got them, then the project went along smoothly. Things that we needed to do is we need to put more devices in place. We need to do a laundry test to make sure the devices held up over laundering. We needed to collect more data, and we needed to continue to support the staff about proper use. Our barriers were staff hesitation and MD concern that they couldn't see the babies just by looking at them outside the isolette. And then what our next steps were in our timeline. So this is kind of the timeline of how our project went. We started in the fall of 2017, I should say 2017. All the typos that you don't notice are there until you're looking at it on the big screen. But in the fall of 2017, I started meeting with our director about the new positioning devices available. We initiated our SVAT meeting, which is our Systems Value Added Task Force, which I'll tell you about in a little bit. We ordered our materials. Our products finally came 3 months later. Then we did our staff education. We placed our first product. We did daily checks every day. The therapy team was checking the positioners, supporting the staff, re-educating, supporting families. We collected data from July, all of July and all of August. And then we did our initial poster presentation in September. So it's pretty quick once we got started. We had to do a report back to the SVAC committee about exactly what the results were to get a permanent product purchase. Okay. Then we did mass staff education after that. And we had our official, this is our plan of care in January of 2019. How do you get your staff involved? That's a good question because our staff was pretty resistant to something new. They're very comfortable with what we were using. There are two levels or opportunities to get your staff involved during quality improvement. The first one is that during the protocol development and testing, and the second one is once that protocol becomes daily practice. Okay. Keys to getting our staff involved included listening at the bedside or in the hallway to any staff complaints and addressing them very quickly and specifically. We followed up on all complaints and asked for more information. We invited staff to participate on the committee, to be a consultant to the committee, or to be a champion of the products at the bedside. We thoroughly educated the staff. Cannot emphasize enough, if you want to change something the staff is doing, you must thoroughly educate them. About the new protocol and how the positioners actually worked. You have to be available nights and weekends for those staff. We have some staff that only work weekends. So if they weren't, we would have never educated them had the team, the committee, not worked on the weekend to educate them. And yes, we stayed at night, not all night, but till like 9 o'clock at night to educate that staff, where we came early in the morning, like at 4 o'clock in the morning to do the education. We asked staff what they thought, constantly asking for feedback for them. And then we made it super easy and convenient for them to give us feedback. We left sheets right on their computer in every room that they could just put a check mark on, or they could write a little comment. We had pictures of each of the devices so they could write a comment on which device they were using or what device they were concerned about. We did a Likert scale at the bedside to gather information. There was no harm in rewarding your staff. And it's a simple reward. When we were doing our education, when staff completed the educational packet, they got a little 3-dimensional sticker that they stuck on their name tag. So it worked 2 ways. 1, they liked getting the sticker, and 2, everyone could see who had completed the education. So then it was kind of like a motivator to get, hey, you don't have your sticker. Did you complete that education? Anyway, so something simple can really make a difference. Our education was very staff friendly. We had hands-on information everywhere, in the bathroom, in the lounge, in the hallways, in all the charting stations, and in the rooms. We had actual dolls and all the positioners available in the lounge that had a pictorial direction of put them this way, now apply this, now apply this, now apply this. And they could actually physically put all the dolls in all the different positioners. We made mini videos. We rolled a cart through the department with all of the dolls and positioners on it, so that every staff who was like lingering or chilling at the nurse's station, we'd pull them in and we'd like, hey, you 3, come on over. Let's get your sticker. Let's get this done. Touch this, feel this, move this. We did that. That was actually a lot of fun. We put all the review forms and all the feedback forms in the patient room, easily accessible. We had committee members collect them so the staff didn't have to drop them off or put them in a special place. We recognized staff for completing their education. Of course, there was always extra committee members floating around during the course of the actual 2 months, July through August. There were extra therapists and committee members that were just floating around days and nights to answer any questions and support staff. We also organized the equipment in an easy to access shelves that had a picture of what a baby should look like in that piece of equipment and what age that piece of equipment would be appropriate for. You can see that here. This is in our utility room. We also invited staff to participate in a manufacturer provided in-service where actually Alex, who's on the call today, provided an in-service to all of our staff who wanted to come. It was an hour, 45 minutes long, and she just went through all the positioners and the background and the engineering behind them and their hopes and perspectives for these pieces of equipment. So what do we actually measure? We measured sleep, proper positioning, and parental perception. In our old positioners, nurses were complaining that the babies were awake. They're awake a lot and they were getting out of the positioners. They were all stretched out and looked uncomfortable. So we went with that comfort, and being asleep was really important to the nurses. So we wanted to measure sleep, that position, and then what did the parents think about these positioners? We used that iPad tool to assess proper positioning. And we have the staff mark down sleep. We'll talk about that a little bit more. I thought this was a great picture because the first picture is the baby at admit, and the second picture is the baby's weeks later, assuming that same sleep position. Our first variable was sleep. We used the bedside time card to mark down every time a baby was sleeping and for how long. We surveyed the nurse's opinion about whether they felt the baby was sleeping longer, shorter, and how long they were asleep. We also allowed parents to mark on that same tracking sheet. It seemed to be very labor intensive at first because at first our babies were awake a lot in our old positioner. So we thought, oh, nurses are going to be marking this down all the time. But actually it turned out to be not labor intensive at all because all they had to check was still sleeping, still sleeping, still sleeping. We changed our average of sleep time from 45 minutes between interruptions to 120 minutes. You can see that demonstrated here in our graph. The gold line represents our goal of 120 minutes, and we surpassed that in the new positioners. And it was immediately present when we did the intervention. We also looked at proper positioning, and this is a picture of the iPad tool that we used. This is still available. I don't know how much longer it'll be available from Philips, but it's still available to use. We did this randomly announced. We just went at all different times on all different days, and staff did not know that we were coming when we came to assess them. And we looked at their positioning pre and post. And here you can see their average score before the intervention was about an 8, almost a 9. And after the intervention, it was pretty consistently an 11, which is a significant improvement in positioning, proper positioning. Parent perception we measured with a Likert scale. I don't have a picture of the ones that we use, but this is just an example of a Likert scale. And we asked them to look at how comfortable did they feel their baby was, from very comfortable and appropriate with their pain managed to uncomfortable, awake, and their pain unmanaged. We initially started out with a score of 3.5, and we were able to increase that to a 4.5 with the introduction of the new positioners. We wanted to make sure that our census wasn't affecting our outcome. So we did also compare our census with our iPad scores, and to make sure that because it was less census, it was easier to get babies well positioned. And if it was busier, they wouldn't be well positioned. But you can see the red line is our unchanging iPad score. It really remained about 11, no matter how many babies we had in the unit. We also did a laundry test. So one of our requirements from the SVAC committee was to make sure that these held up in the laundry. So we did 5 laundry cycles. We washed all the positioners together in one big bunch. We did separate it from the other NICU laundry, but it was washed in our commercial system at our commercial temperature, down in the basement, and then returned up to the unit. The stretch knit products held up very well, staying exactly like new for 5 cycles. And our DandleLION product, which is a single-use disposable product, it did start to show wear after the 5th cycle and was no longer usable, but still held up for 5 cycles when DandleLION told us it would only hold up, it should only hold up for 1. The final product. Using our quality improvement tool, we were able to demonstrate improved sleep, position, and parent perception of comfort over a 3-month period after changing to a novel positioning device. These devices demonstrated significantly improved outcomes for longer sleep, improved posture, and parent perception. Given how much sleep babies gained, we were able to reduce the number of PRN pain medications, which would have been a great variable. Had I known, it would have been a great variable to measure. We were also able to improve weight gain velocity, so the babies gained weight faster, also a great variable, but again, didn't know that was going to happen, so I didn't measure that. If we take a closer look, you can see that we used all the positioners that we were purchased. That was 1 case of each of the positioners in 1 size only. Parent comments included, baby's very comfortable, it's easy to use, baby never wakes up when they're in the wrap, babies sleep so much longer. That was such a common comment. Babies sleep so much longer, and they look just like they did in the womb. Following completion of the study, we transitioned to a performance improvement project where we followed the positioners over the course of the next year. And I'm happy to report that we continue to have success with both sleep, parent perception, and proper posture. I want to thank Kathy for inviting me to speak. It's really exciting to share this information. I know that using this quality improvement project made a huge difference in our staff buy-in, as well as our financial buy-in. I want to thank our families for providing those great pictures. And I want to thank all of you for listening. And I hope that I have inspired you and motivated you to perform a quality improvement project in your own setting, because it can make a real difference. Thank you.
Wow, Elizabeth, thank you so much. And I have to be honest with everyone. I mean, we knew that Elizabeth ended up choosing DandleLION, but I learned things from her. I had no idea that it was as successful and that it was what it was compared against. I never knew any of that. So I mean, my heart is just so warmed by this. Thank you so much. I'm really, honestly, just so grateful for all this. So I would like to turn it over now for questions and answers. I'm sure a lot of you have them. Down at the bottom of your Zoom screen, there's a Q&A button down there. If you just click on that. We have some questions already. Kathy Randall is going to help us out and kind of feed the questions to Elizabeth, so they'll be available on the recording that you will all get afterwards.
Yeah, let me just echo that, Kathy. I mean, wow, Elizabeth, that was so good. And there were so many layers to this presentation that I just was blown away. I mean, I see Alex is nodding too. So we're both feeling like the nurse in us is like gobbling it up. So we love this. So one question Katie has is, how did you measure sleep? Can you share what tool you used or what technique you used for that?
Okay, we didn't use a commercially available tool. That really wasn't in our budget to purchase a new tool to measure these variables. So what we simply did is we had a tally sheet in the bed, in the room. The nurse came in. When they came in to do their cares, they just marked, was the baby asleep or awake? So every time they came in. So we do 1 hour rounding. So every hour a nurse has to go in that room and just check on what's happening. So every hour they were able to tell us, are they asleep or awake, asleep or awake? And then we just compared that before and after to get that data of about 45 minutes. Every 45 minutes, our babies were getting interrupted on average, not all the time, but on average to 120 minutes. We actually had some babies that made it 160 minutes of sleeping without interruption.
Wow.
It was a huge difference.
Wow. That's really great. I mean, I just was thinking on that one slide, I was thinking like each of these single outcomes are like an amazing QI and PI project. And I love how you talked about the difference between those. I thought that really helped everyone to frame the projects we do in just a totally different light and to maybe name them what they really are. People are just saying, awesome, awesome, awesome. So I guess just a couple housekeeping things. The recording is always posted, and then you get an email that you can forward on to others if you need to. Elizabeth was so generous to create a PDF of her slides. And if you pre-registered before yesterday, you would have received that in your follow-up email. If you just hopped on today, you maybe didn't get those, but they'll be posted on our resource page that have all of the the recording and the evaluation form and her slides and handouts. And so I hope that answers those kind of housekeeping things. People are so excited, they want to share. This is kind of a staffing question for you, Elizabeth, which is, you stated half of your time is bedside. And so how did you negotiate this split of your time?
When I was hired, I really have had an enchanted career here. So when I was hired in 2004, we were just building our private room NICU. And they didn't have any employee, any position that was going to create programming around that new environment. And because of the work I had done at the hospital I worked at before, they thought that I would be a good fit because of my interest in developmental care, because of the certifications that I had acquired, my knowledge level. And they really wanted someone who wasn't necessarily a nurse that could come in and create those protocols and policies and do the education. And I was just really lucky to get the job when I got the job. So I was hired as a developmental specialist, but because I'm a physical therapist, I don't fall under the cost center of women's and children's. They don't employ therapists under women's and children. All therapists are employed under the rehab medicine model. So because I was a physical therapist, our agreement was I had to pay for my time in the NICU by providing direct patient care. And then just working with our administration, we came up with this kind of 50-50 split. Most days are direct patient care. And then every so often I'll take a whole day and do developmental care. More like putting out fires versus kind of a constant flow. I wish it was a constant flow, but when you work in NICU, sometimes you have a lot of patient care to do.
Yeah, for sure. So can you explain a little bit again? I know Kathy outlined at the beginning your certifications. There was a kind of a long laundry list of things you've done to get where you are, but maybe you can inspire people to, start collecting some initials.
Sure. Well, I can support all of the things I've completed all as valuable. So when I started my career in the early 90s, when NIDCAP was just coming out and being really integrated into hospitals across the country, our hospital brought in Heidi Lees and Gretchen Lawhon, and we had a team of about 20 people who went through NIDCAP training. At that time, they didn't allow the therapists to get NIDCAP certified. They separated us into infant behavioral assessment certification. So you got all the NIDCAP training, but your certification actually was an infant behavioral assessment versus NIDCAP. But it was the same training, like all the instructors did the training together and the team was trained at the same time with the same information. So NIDCAP training can't underscore enough how that sets the whole tone for the developmental care philosophy. After that, we did neonatal neurobehavioral assessment scale, which we've used in our research projects in our unit. We're currently recertifying for that because we're doing some new research on management of pharmacological management of neonatal abstinence. So got that. That's a great tool to use in NICU to assess function of babies. We did that. We did neonatal touch and massage certification, which again is kind of like application of NIDCAP principles literally at the bedside with the babies. How am I handling them? What is my touch doing? What is it? Why is this posture so important? Why is it so, why does the equipment matter? Why does my intention matter? Why does my attitude matter? So that really helps with that direct patient care. All of them I've really liked. I'd love to get general movement assessment certified. I would love that. Currently not available in the United States, but someday. They're just a variety. I think it's really important to understand the nurse's perspective, and NIDCAP really helps you understand the nurse's perspective. I think that's really important. I think understanding what a neonatal therapist is supposed to be doing, so certified neonatal therapy, I think that's really important for working in a unit. And plus, because I'm that type 1 perfectionist person, I just feel like I just have to know everything. Got to know everything all the time.
Yeah, I have that same gene, I think. There's a couple product questions. I think I might hold those till the end because they're kind of product specific. So people are just saying, so how did nursing staff feel about positioning aids restricting visual observation, especially in relation to work of breathing or abdominal distension? Did they become more dependent on the monitors? How did they balance those things?
Great question. Everybody asks that. That's a great question. All of our new physicians ask that question. All of our new nurses are uncomfortable with that. Our physicians actually gave me a pretty hard time when we did the quality improvement project because they couldn't see the babies. And then not only couldn't see them, but once they figured out how to get them undone, they couldn't figure out how to get them done again. Anyway, so it's a great question. So what we've done is you can modify how the DandleLION positioners are used to allow you to have visualization of the abdomen. You can use different arrangement of the products to allow you to have visualization of the chest jiggle with high flow, with high frequency ventilation. It's possible to use 2 pieces of equipment together if you have an arm that has to be an extension because of your PICC line flow. So really by using multiple products, you can meet every need that the baby might have for visualization as well as still proper posture.
Great, love that. There were a couple questions in the chat just related to various outcomes in your project. And so, you selected a few outcomes, but they wondered if maybe you have seen and just didn't report yet on improvements of plagiocephaly, as well as weight gain. There was one more, I'm just scrolling, and length of stay. So have you looked at any of those, or are you maybe digging into those?
I haven't dug into those because I'm on to the next, next great thing. But I will say that after the project, I didn't really realize the impact. I mean, I knew in my head the impact of sleep on weight gain, but I didn't realize that we would have such an improvement in the amount of sleep that it would be enough to affect weight gain.
Mm-hmm.
And we definitely saw, not necessarily that the babies weighed a lot more, but their rate of growth improved significantly because they were getting more sleep. But I didn't measure that because that wasn't a variable I even knew would happen. So I didn't measure that. In someone else's project, you could measure weight gain velocity. You certainly could measure, again, like that number of PRN medications. PRN medications, a big JACO hot thing, like they don't want you doing those. And being able to have something external that allows you to use less medication is something you could measure that. You can measure how many doses before, how many doses after. It'd be a great variable to measure. But again, I didn't realize that was what was going to happen, so I didn't measure it. What was the third one, Kathy? Sleep.
Excellent. I think you got them all. Weight gain, length of stay, and plagiocephaly.
Length of stay. Okay, length of stay. So hard to isolate that variable. So hard. We did measure length of stay when we did infant-driven Q-based feeding, but it's so hard to measure it. There's so many variables that affect length of stay. So that's a hard one to choose as your variable because there's so many process metrics that affect that. Plagiocephaly. So we never really had a problem with plagiocephaly. We have a very strong IVH prevention program for head and midline. So actually we had we're like over cautious about head and midline. So our heads were staying in midline a long time, but we did have a problem when they went to the crib. So that goes back to the study we did on preventing positional plagiocephaly, but that for us happens in the crib versus in the isolate.
Got it. Got it.
Midline makes products to hold that head in midline, and they make the new mattress to even from the very beginning at admission now that you can use.
Excellent. Excellent. I think, yeah, those were, I tried to kind of combine a couple there together. A couple people are just asking about kind of overall staffing in your unit. I mean, again, it sounds like a dream where you work and all the support that you and your team have. So how many therapists are in your unit, and remind us how many beds you have in your NICU? And then how do you staff for this kind of one-on-one education that you do? How do you staff for that for day shift and night shift? How do you get that translation to all the shifts?
So many questions. Okay.
I know, sorry.
We have 62 beds and we can flex up to 72 if we move over to the castle. Our average census is in 40 to 50. We have 6 neonatal therapists. Like, it's amazing. We have a great team, 2 PT, 2 OT, 2 speech in our unit. We have orders on every baby. So if you have 60 babies, that means 10 babies per person, basically.
Mm-hmm.
But we don't divide it that way, of course, because speech therapist doesn't see everybody anyway. But we have 6 therapists in a 62-bed unit. Our time for one-to-one education is our committee for this project was made up of bedside nurses, a nurse practitioner, a physician, and then all the therapists. So between the nurses, and we pick nurses who work day shift and night shift, and we even had one of those weekend-only nurses on the committee. So that really helped because they were already working those shifts. We had to accommodate the schedule, we had to flex our hours. So you couldn't work, I normally work from 6:30 till 4. But you couldn't work 6:30 to 4 and then still be there at 9. So if you were going to be there at 9, then you had to come in at, 10. So we were allowed to flex our hours to be there at night, but you couldn't work like 16 hours. They weren't going for that. No.
Nice. I think that's great that you were able to do that. I mean, sometimes it feels like some of those other partners that we have that are from other, maybe, owned by other departments, there's not that flexibility that's just kind of that normal consultant hours. So that sounds amazing that you were able to do that. A couple just questions about practical day-to-day life in the NICU. Maybe how do you support staff who are positioning and the baby has umbilical lines? So maybe you want to start with that one.
Sure. We use for our umbilical lines, that's going to be in our newest babies, not necessarily our youngest babies, but we use umbilical lines at admission pretty commonly. And at admission, we admit to the DandleLION because most of our babies end up on Billy lights within 24, 48 hours. So we just admit to the DandleLION, and it works really well to roll that down. So it looks like a bikini. They have a strap. The one of the positioners goes over the arms, which holds the arms in place, and then we roll down the longer overwrap. I call it an overwrap. So it's just below those umbilical lines. So you can see them. We tape and suture our umbilical lines in place. We're using a new thing called a bridge. I'm not sure who makes it, but it's a little bridge, so it holds the lines up off the abdomen. And that works really well because it stands up against the abdomen, so you can't put the positioner over it. So it just goes underneath. And it works very well. We use umbilical lines all the time.
All the time. What about postural support during kangaroo care? Do you use products? How do you transition the baby between those? Tips on that?
Oh, great. These are great questions. Okay, so our babies are in the positioners, in the isolette. We use a standing transfer where the parent is picking up the baby. Even our babies on ventilators, we have 3 people that are helping. There's a nurse or a respiratory therapist who's holding the ET tube in place so it's not moving. We have someone who's moving all the lines and tubes and cords, and then the parent just picks the baby. You can just pick them right up out of the positioner because they're already in this beautiful flexion position. Pick them right up and put them to the chest. We don't currently hold with any devices. We did do a study 2 years ago on using a wrap for holding with skin to skin. That was a great example of how my timing was off with our unit goals and implementing a good project because we demonstrated that the wrap really improved everything we were looking at: parental confidence, length and duration, frequency of skin to skin holding. But we weren't in a place to buy the wraps. We bought some wraps for the study, but then they didn't want to buy the wraps either. So we aren't using the wraps currently. Hopefully in the future we'll be able to use those, but we don't use any other positioning equipment with skin to skin holding.
Great. Any tips on positional products that you use specifically for babies who are intubated? You mentioned, exposure of the chest, like for kids on hi-fi, but any just other kind of quick tips you could give on that?
Well, I'll say one of the big differences between our previous positioning equipment and the current one is where the hood is. So in our previous ones, the hood went around the legs and hips, which was great. It was great. It really helped hold that lower body in good flexion. But there wasn't anything around their head. So you always had to add something around their head. And then the height or width of it was variable. So we were always stacking fabric materials to hold the tubing up off the surface of the bed. With the new positioners, with the DandleLION positioners, the way their hood works around their head is it's bifold. I'm not sure what all these terms are, but you can fold it down. So when it's all the way up, it provides wonderful light shading for the baby, like the brim of a hat, but you can fold it in half and then it's just the right size for the tubing to lay on. So it actually supports the tubing. We even use it with our high frequency babies and we use oscillators and high frequency jet ventilators also. And we've had much better success with keeping their head in midline and keeping the tubing supported using the DandleLION product around their head. That's worked really well. And our staff love the DandlePal because it has the extra little lip that you can wrap around to make it taller. And that's really helpful as well. I remember, it's funny, I remember when we got the DandleLION Pal and everyone said, "What the heck is this?" They're holding it by the little strap. "What the heck is this? What's this for? I don't like it." And then we just showed them how you can wrap it and they're like, "Oh, this is great. It's exactly what I wanted." So that really does help, especially for intubated babies.
Excellent. There is a question about how does your system bill for these devices? So there's a lot of different products you're using, and how do you manage that in your system?
I'm not sure, because I try not to pay attention to how costs get covered. But we were in our old positioners, each one was individually billed. Like a baby might have gotten 5 snuggle-ups and they got billed. Each one had its own little sticker that you peeled off and stuck on the card, and they got billed for those. And then towards the end of the use of those, so towards 2017, 2018, our hospital determined that you really shouldn't be billing for something that you used to promote good care. So then we didn't bill for those anymore. And when we brought the new products in, we never billed for them. So they're just built into the cost of care per day for the babies. So we don't charge for them.
Okay. I hope that helped to answer that person. Do you have any infection control issues? Length of duration for use or product? How often do you change products, etc.?
Great. Again, great questions. And our infection control group, they cared about this. Oh yeah. That is why all of our products get washed in the commercial laundry. They all go down with the gowns and the sheets and the diaper pads. They all go down to our commercial laundry. We're lucky we have commercial laundry in-house. So we're able to launder that and then get them back up onto the floor. We have, when you talk to the company representatives, I'm sure Kathy can speak to this, the DandleLION is single patient use. We do reuse them sometimes. We're definitely reusing our DandleRoos and our Dandle wraps and our pals and our cozy cups. We reuse all of those. We currently are on a 3-month basis, so we order 3 cases every 3 months. It's enough for us. We always have equipment. Our biggest challenge was with COVID. Our laundry people were getting sick a lot, and we didn't have many staff working in the laundry. So then our stuff would go down and it didn't come back up. So that was a problem that we experienced. And what we did is we had to get a staff member from the unit to go down to the laundry and go pick them up. And so we had this pickup person for a couple of months. That seems to have resolved now that our big surge has been over, and now our staff's pretty completed. So that seems to have resolved. They do go down to laundry. Then we do have a person who initially was me, because I'm most invested in this process, who when the laundry came back up, it just comes up all in a ball, all mixed together. And I took the time to separate it all and realign it all so that the nurse could just reach in the bin and pick it up exactly how it's supposed to be used and go put it on a baby. We've now transitioned that to one of our unit clerks, who the laundry comes up and she goes in and she checks it and she reorganizes it and gets it all on the shelves. So it's really important in our unit that the equipment we're using be nurse ready. So the nurse can just pick it out and use it. Our nurses don't want to untangle it. They don't want to fix the Velcro on it. They want it to just be ready to pick and go. That really improves buy-in and use. Anyway, so we had to have one of our unit secretaries who I trained on what they're supposed to look like, and she keeps them updated. Mm-hmm.
Excellent. That's kind of dovetails nicely into one question somebody had about how do you keep from losing any of the smaller Velcro parts? Do you have any tips for that?
Yep.
We lose them.
We do lose them. We lose the little hip bumper a lot. We lose it a lot, and you can buy those extra separate. So I don't know that they're super expensive or not expensive, but we do just buy extra of those. They come in $25 each. Just every 3 months we buy a new package of them, so we always have extra hip bumpers. Mm-hmm. And yeah, you do lose them. Yeah, sometimes I go into the drawer underneath the isolette and there's like 4 of them in there. I'm like, what's going on with these? Yeah.
There's kind of a longer question here from Pooja. I'm trying to answer or trying to read really quickly to make sure. Maybe it's just more of a comment than a question. So, I mean, maybe let's kind of dovetail that question that's a little bit longer in with one of the last ones, which is all of this, we're all inspired, but we all work in different units. We don't all work with you. Well, maybe some of your colleagues are here, but can you give people a tip to how do you work through culture change? Just maybe a few of your top nuggets. I know you've sprinkled many through the presentation, and I heard listening, at the bedside listening, but maybe you can just give people a couple just final words of wisdom on, how to stay, motivated and resilient through the challenges that happen when we're making big change in the unit.
I can really talk to this because as much as positioning was a huge culture shift, infant-driven feeding was 10 times more of a culture shift for our staff. I would say, if I had to name the top 3, I would say saturation of education. You have got to saturate them. It's got to be everywhere, all the time. Their questions have to be answered right away. As soon as you know about those questions, you've got to answer them. So saturation, 1. 2, enthusiasm. You have got to love what you're doing and spread that love to others. Like, people call me, if you're in our unit, you would know I have this reputation of being too much because I'm just always talking about it. Somebody asked me one little question. I'm like, oh, let me tell you how the brain develops. Like, it starts and 20 minutes later, they're like, oh, stop talking about the brain.
They're like, where's the Velcro piece?
Yes, exactly. Anyway, so enthusiasm, saturation, and then using the language and the processes that nurses are used to. Therapists learn a whole different way of changing things and a whole different way of doing things than nurses do. So you must, especially if you're not a nurse, you have got to get on the ground level of what happens in a nurse's day, what do nurses care about, what are their expectations, how many things are on there, what we call Stanford Learn. Our nurses get like 28 of those disposed every 2 months. Like, it's crazy. But you have to know that. You have to know, like, what am I expecting of this nurse and what is everybody else expecting? Okay, 4, I'll give you 4. 4th one is, do not do a culture change initiative when you're also doing an initiative for something big, something else. So when we changed all our ventilators, that was not the time to do anything with positioning. So you got to really, what's the timeline of things in your unit, and know when's a good time to do this. Don't compete with other really important changes. Okay.
So good. Alex, did I miss anything in the chat or anything else you want to add?
No, I think just to tag on to what Elizabeth just said, I think, we learn in nursing, I'm a nurse. So we learn in nursing school, the first step of the nursing process is assessment. And that's equally as true with any kind of quality improvement or performance improvement, not only assessing the problem that you think you have and the severity and the depth and the factors that influence it, but assessing the learners of the new process, assessing their daily environment, assessing their baseline knowledge, assessing their attitudes, assessing their barriers, what is their stress. To Elizabeth's point, if the hospital just passed down some sort of crazy staffing change and everyone's angry, like, that's not the time to say, guess what, we're getting new positioners today. Everyone's going to go, what? Leave me alone. You seem kind of unplugged from what's happening. So that assessment needs to be very broad and not only material things that you're assessing, but like attitudes and culture and all that kind of stuff. So just don't forget the importance of assessment when you're going to start managing a change.
Excellent. Well said. Well, obviously, this is an extremely important topic. I think you've engaged everyone, Elizabeth. We still have 110 people here live. So I'll let Kathy do the final wrap up, and I'll give my own personal thanks. That was amazing. Thank you so much.
No, thank you. Thank you, Elizabeth. I mean, we're at DandleLION. We are so grateful to have experts like Elizabeth as part of our webinar series. Sharing of information like this is just so invaluable. And I'm just going to do I don't usually do this right away. I will tell you how to get your CEUs, but DandleLION has really jumped in with Philips withdrawing from the market. There's been a big gap in the positioning aids. And I want you to know we've done a number of things to step up. One, we have Alex as our new director of education. She has an amazing education team of consultants that are willing to work with you one-on-one with your hospital and your team. She'll, meet with you individually via Zoom, and we have in-service videos, we have pictorial instructions, we have so many other resources to help with staff education. I also wanted to let you know that hopefully within 2 weeks, we have a number of products that are going to be coming out that may help you fill any gaps that you're seeing with the Phillips Law. Some of you have laundry challenges, some of you have other needs, and we are coming out really quickly with quality products that are going to help you out. So we'll send that announcement out to our webinar list. So be waiting to see that. And we're happy to help. We're really, really excited about this opportunity, and we have really leaned into it hard and hope that we're going to be able to meet all your positioning needs in the best way possible. So in order to receive your free CE, you're going to need to fill out the evaluation form. Once we're done here, you're going to be automatically redirected to the evaluation site. If you're watching the recording, please go back to the email you received with the link to the recording, and there is also a link to the evaluation form. And then once you fill out the evaluation, it will take about a day or so for you to get the CE certificate in your email. All the webinars for the last 3 years are still good and available for free CEs. And again, if you have any other questions, we've put Alex's email and my email are up. I hope, Kathy Randall, did you have those email addresses up at all? Contact either of us right away if you'd like to, look into having a consultation, especially with Alex and the team. We're happy to help you. We know this is a really stressful time. Elizabeth was able to plan for this change. Many of you are not able to plan for it. So we have a wealth of information. Elizabeth is willing to, help us as well and meet with your team too. So please, switching is easier than you think, and we're here to help you. So thank you all for staying on for such a long time. Thank you, Elizabeth, again, for just a fabulous, fabulous webinar. And we'll see you all in a couple of months for our next DandleLION webinar. Have a great rest of the day.
Just for those of you who are looking for the link, it'll appear as soon as this window closes. So I will close it and you'll be redirected right away.